Okay, I'm going to hand over now to the team in Bangor and would like to very much welcome Professor Robert Higo, who's Honorary Consultant Psychiatrist at the Wrexham Academic Unit at Betsy Cadwallader University Health Board and at the School of Health Sciences at Bangor University. Dr. John Carden, who's Mental Health Nurse, Betsy Cadwallader University Health Board and Honorary Lecturer at Bangor University, and Dr. Sadia Nafis, who's Research Officer at the School of Health Sciences at Bangor University. So I'll switch myself off and hand myself over to the Bangor team.
Can you hear us proper?
Yes, we can.
Yeah, thank you. Thank you so much, Claire. It's a privilege to represent this on behalf of my team. Can I have the next slide, please? Thank you. Just to take you through the agenda of today's presentation, we did a literature review to gather the evidence, and we'll talk about the research method very briefly. Mainly it will be the findings and the results, what we found in the evidence, taking you through the primary studies reviews, the resources we found online, the RDSSS data, men's group, and the conclusion. Next one, please. Thank you. First and foremost, what is out there that we were looking at in terms of the research questions? Gathering the evidence about male suicide prevention strategies, as well as what methods are used, about the effectiveness of male suicide prevention strategies. I won't go into details about the research methods, but how we did it, we did a scoping review to conduct a timely, up-to-date scoping review about the interventions, as well as we had mainly the focus on Wales, looking through what is out there in the world as well as in the UK, and then bringing it down to the Wales. My colleagues here will take you through the findings, but I would like to just talk about, like, we started with thousands of the papers, but we ended up with 530. Out of those ones having precise criteria, we have found primary studies 42, reviews 13, and many online resources which we gathered together in 21. For those who may have interest in research, we found different electronic databases, and we prioritized the relevance against the quality of the available evidence, because we wanted to capture all the interventions available out there. Next slide, please. And that's where I will hand it over to Dr. Roberts to take us through the results and findings. Thank you.
Right, next slide, please. So I'm Dr. Higo, I'm not a professor. I'm not sure if that's a promotion or a demotion. We divided the primary studies into 5 groups. There is some overlap between them. So the first one I'd like to talk about is those studies that examined the impact of therapies. The therapies mostly were CBT, that's cognitive behavior therapy, but there was also a study of dialectical behavior therapy, that's DBT, and there was one study that compared 3 different types of psychological therapies. Study populations are quite often US veterans. They're a much studied group because there is quite a significant rate of suicide in that group. But there are also studies of men in suicidal crisis and a study of prisoners at risk of suicide in an English prison. The outcome measures that the studies use are typically proxies for suicide, such as whether people have suicidal ideas, whether they suffer from a depressed mood, and whether they're anxious. And then the study measures to see whether you make significant changes to those characteristics. Typically, the studies show a significant reduction in suicidal ideas and/or depression or anxiety. And that's not surprising because we know that these therapies are effective. The study of prisoners was interesting because it showed that it is possible to deliver CBT to prisoners who are at risk of suicide. And it was possible to demonstrate a reduction in self-harming behavior and a reduction in depression and suicidal ideas. So those are the studies that we looked at with respect to therapies. Next slide, please. There are other face-to-face interventions that were included in the literature search. That's a very heterogeneous group, and the sort of interventions varied quite a lot. It's difficult to draw any meaningful conclusions from them because, as I say, quite a lot of these studies involve particular groups. I will talk later about James's place because I think that's quite an interesting model that people might be interested in hearing about. So I'll talk more about that in a later slide. Next slide, please. There are a range of studies looking at the feasibility and impact of training. Some of the studies come from Australia, and they were targeting managers and workers in the construction industry and in the energy industry. And what the studies were able to demonstrate was that post-training, there was an increased awareness, increased knowledge, and a positive change in attitudes towards offering and seeking help with respect to suicide. There's a study of training in clinicians which shows that if you increase their confidence in the skills that they have, they are more likely to incorporate good clinical practice into their practice. Another interesting study was done by the Samaritans, and that showed that web-based training is as effective as in-person training for imparting knowledge, self-efficacy, and likely behavioral intentions. Next slide, please. Sorry. There are two studies from the US looking at the impact of helplines. There was a study targeting US veterans, which was implemented in 2007, and after 3 years, they had received 171,000 calls. 70% of those callers were male, typically in the age group 40 to 69. And as a consequence of those calls, 4,000 referrals were made to mental health services. A further study looked at using a helpline to monitor the progress of US veterans who had been discharged from nursing facilities in terms of monitoring their mental health in the absence of any other more conventional monitoring of mental health that might have been delivered. That study showed that it was feasible to set up such a service, and the recipients of the service found it helpful. Okay, next slide, please. We found 3 studies examining the impact of campaigns around suicide prevention. First was with respect to an Australian campaign which was called Silence is Deadly. It was aimed at Australian schools, targeting young men, and it led to an increase in help-seeking by the recipients. They were more likely to seek help from their friends, but there wasn't actually a change in their likelihood of seeking help from other sources. There's a study of the effectiveness of national suicide prevention programs, and this is a very interesting study. It compared 4 countries that have well-established suicide prevention programs: Australia, Finland, Norway, and Sweden, and they all implemented national programs in the 1990s, beg your pardon. And the comparison countries which did not have such programs were Canada, Austria, Switzerland, and Denmark. They very carefully matched the intervention countries, i.e. Australia, Finland, etc., against the others in terms of the culture and religion, the socio-economic structure, population size, quality of data, and so on and so forth, to make them valid comparisons. And they were able to demonstrate that national suicide prevention programs led to a statistically significant reduction in suicide for men in the age groups 25 to 44 and 45 to 64. I'm not going to go into the mathematical analysis, it's quite complicated, but the methodology looks pretty sound. And then there was a study of the Choose Life campaign in Scotland, and they were able to demonstrate that that led to a significant increase in suicide awareness among a large portion of the target population, and there was a positive impact on their attitudes and behaviours with respect to suicide risk. And they noted that a good location to reach young men are rather sports and leisure facilities. Okay, next slide, please. I said I'd say a bit more about James's Place as one of the face-to-face interventions. So James's Place was initially instituted in Liverpool, and it follows a brief psychological model for helping people in suicidal crisis. It's a community-based program that took care to develop a non-institutional environment, and they were careful in setting up the service to involve stakeholders, service users, and those with lived experience of suicidal crises. They offer a 9-session therapeutic intervention around initial assessment and safety planning, sessions targeting the particular problems of the individual men, be they employment issues, debt, bereavement, relationship breakdown, which they note are often very important factors in bringing men to suicidal crises. So there are 3 studies that look at James's Place in terms of the outcomes, the men they were able to reach, and what had brought them to crisis. Next slide, please. So it would also be worth just outlining the Finnish National Suicide Prevention Programme, which I mentioned previously had been shown to lead to a significant reduction in suicide in men of particular age groups. I think the important thing to note here is that a National Suicide Prevention Programme covers a range of things. Awareness raising, looking at impacting on the means of suicide, intervening early when men are in crisis, supporting high-risk groups, developing realistic care options, increasing media competence with respect to suicide, looking at the knowledge base and facilitating improved research, and then finally monitoring the the progress of the programme. Thank you. I'll hand over to John Cotton now.
Okay, thanks, Robert. Good afternoon, everybody. Could you have the next slide, please? And the next one, please. Okay, I just wanted to say as well, with our search, we're cognizant of the fact that with any review, with any scope and review, we're probably going to miss some papers and studies. So we thought we'd add that as a caveat, really, because it seems to happen in all systematic reviews and reviews. So I'm sure our academic colleagues might identify some studies that we may have missed out on. So we had a look at these reviews, 13 systematic reviews, scope and reviews, and 1 integrative review. And what we're cognizant of is that not all the reviews are focused on preventative interventions, specifically with males. And the rationale for including some of these is that given the high rates of suicide within the male group, the caveat is that potentially all interventions are targeted at males. So that was the rationale for including a range of systematic reviews, not specifically targeting male suicide prevention. In the report that we're going to produce, where we can, we try to extract some of the data, but that's not always possible. And we'll make specific reference to studies within the reviews that have a particularly high male ratio of participants in them. So just thought to briefly mention that. Can you have the next slide, please? This is just really a list of the reviews that we have looked at and tried to extract some of the data. And as you'll see, a lot of them are mainly carried out with the general population. Some have examined particular aspects of interventions, again, not specifically targeted at men. Next slide, please. Here's the list again of further systematic reviews. Again, you'll see there that again that they're not specifically targeted at men, but more generically aimed at the population. Next slide, please. So this is some of the findings that we arrived at. Now, as opposed to looking at individual studies, when you start to examine systematic reviews, you start to look much more at the quality of the studies that are included. There's usually an assessment of the quality of the studies, of the rigour and the validity of the studies that have taken place. And like a lot of systematic reviews, they normally make a lot of comments about the strength of the studies within the review. Now, the area of suicide prevention is unsurprisingly incorporates a number of studies that have got a significant amount of methodological weaknesses, and this was the most common statement within all the reviews, specifically the systematic reviews where they had to assess the robustness and the quality of the studies. This was the most common statement made. So I think that's something we should recognise, really, that the quality of the evidence is not very strong, we have to say, and that's why it's difficult to come up with specific recommendations, because sometimes they're based on not very good evidence, so we need to be mindful of that. Unsurprisingly, and in a number of the systematic reviews we looked at, where they examined interventions, a number of interventions over a period of years, means restriction appeared to offer the best evidence. Specifically where they look at a range of interventions where they look at barriers and bridges, nets, etc. Firearms restriction, mainly in the US and some European countries. Gas detoxification, that's happened in the UK and other countries. And restricting the amounts of over-the-counter medication, barbiturates, etc. This is where the best evidence seems to lie, and the most effective evidence of interventions that have taken place. But obviously these are population-based interventions, so we need to be mindful of that caveat of a male-only participant group. Where we identify gatekeeper training, you know, Robert mentioned it earlier on, where some of the studies have tried to train individuals around identifying suicides in various organisations, workplaces, schools, universities, prisons, etc., etc. The acquisition of knowledge can be quite effective, but that will tend to ease off over time, and that will tend to sort of dilute over time. But it seems to be more effective, this element of gatekeeper training, where the roles are formalised and there's treatment pathways or signposting open to those gatekeepers that have been trained. So I think that's an important finding, specifically what we're going to talk about later on in terms of the men's group. Next slide, please. There was quite a large systematic review of preventative interventions for people in contact with the criminal justice system. We identified that there was a number of studies, again, that show some promise of benefits of reducing suicidal ideation and suicidal behaviours. And these tend to be some of the stuff that Robert has mentioned earlier on, but also identifying mental health awareness of programs, education, peer support. It seems to be a strong intervention that takes place in prisons. But as I mentioned earlier on, the quality and evaluation of some of these studies leaves a lot to be desired, and we have to note some of these findings with some caution. But again, what we thought we'd identify is that vulnerability screening within prisons, especially new prisons in Wales and the range of prisons in Wales, should be one of the outcomes from that review. We found that age-specific mental health awareness and education in schools can be effective in reducing ideation and particularly suicidal behaviour. We know that younger people and the age group of males, the age group of people taking their own life is increasing in the younger age group, and we understand that age-specific interventions for young men can be effective, but the interventions should not be adult replicated interventions, i.e., young men going to university and later age teenagers. These need to be age specific. There's no specific identification of what these interventions are, but they recognise that we shouldn't just replicate what we do with middle-aged men, with young men and late-age teenagers. Next slide, please. We know that psychotherapy, CBT and DBT can be effective, but particularly effective after an attempt someone makes on their own life. This appeared to show some reasonable evidence of effectiveness where people are followed up robustly and assertively and offered and indeed engaged in various type of psychotherapies. That can be quite an effective intervention. Psychosocial interventions. This was one systematic review that we looked at. These are a range of interventions such as cognitive behavioural therapy for psychotic symptoms, mood disorders, etc., medication management, relapse planning, family intervention with psychosis, etc. There was one specific study that showed that predominantly had a male range of participants that showed good evidence of effectiveness in reducing suicidal behaviour. We've got evidence from one area in Betsy Cadwallader, one early intervention team in one section of North Wales that show participants of two-thirds of young men are in this service, and therefore we thought we'd highlight the effectiveness of PSI interventions with that population. But we'd also thought we'd recognise that, I mean, these interventions should be available across all mental health services, and they're not really. They're mainly focused in these teams that are fairly new within Wales. I know they've been established in England for about 20-something years, but they're fairly new within Wales and very new in North Wales. And we know they're not in all areas, specifically in North Wales and other areas of Wales as well. Next slide, please. Is that over to you, Ross? Yeah, just hand over to Robert, please.
Okay. So with respect to online resources, bear in mind that this is what we've been asked to do is look for the evidence of the effectiveness of interventions. So anything I say is not meant to be at all critical of the online resources. The issue really is that we don't have good evidence about what they achieve. That isn't to knock them at all. And I'm aware that many organisations that provide online resources are present in this meeting today. There's a huge range, and they provide a great deal of what one would assume to be useful interventions, i.e. they provide information about suicide and suicide risk. They sometimes provide links to training, access to helplines, links to face-to-face groups, and links to campaigns around suicide prevention. What you can do in some studies is see evidence of the amount of web traffic, and to some extent you can follow up what links that the people who visit a particular website, what links they click on, and what links they then follow on from there. What we don't know is what benefit they draw from the resources, but just to stress, I'm not being negative about it. I'm just saying we don't have clear evidence about that. I think we could comfortably say that collectively they raise awareness about the importance of suicide and the need for action, and they provide links to services that one would assume would make a positive impact on suicide prevention. Okay.
Yeah. Next slide, please. Okay, just before I talk about conclusions, I think there was actually one slide we missed out there, because I thought my section was a bit short.
It's about 5 slides back.
Yeah. If I could just talk about that anyway. We looked at studies about rural interventions in suicidal-based interventions in rural settings. The evidence was not very strong, and the quality of the studies were quite poor in some areas. Not all the studies did report it. But what we're aware of is that the real-time suspected surveillance data does demonstrate in Wales a higher rates of completed suicide in these areas. So although the evidence doesn't show the effectiveness within the quality of the studies, we recognise this is an area for specific intervention, and would endorse some of that. We also looked at peer-based interventions. Yes, that's the one, yeah. And we recognise that, as I mentioned earlier on, some of the areas where peer-based interventions can be effective are things like, prisons, workplaces. The men's group, they seem to be a core of the men's group where you're engaging with some of your peers, and these can show some evidence of effect, because I think men relate to this in terms of they're not being judged, speaking to trusted people that they know, and these are some of the issues that men identify that prevents them from maybe trusting organisations or statutory services that they come into contact with. In terms of the quality of the research, I've also mentioned that, but there's a dearth of qualitative research with men. Rory O'Connor and his group and one of the scope reviews we looked at identified this and highlighted this as an area that needs significant attention. And some of the areas that Rory O'Connor's group looked at were loneliness and isolation, feelings of failure and sources of stress, and how men manage emotional pain. And these seem to be the main areas, and more research needs to take place in this area. And again, Dr. Robert Higo has highlighted the effectiveness of online resources and the challenging nature of trying to evaluate these specifically in terms of how good they are in preventing suicide. Could we click on to conclusions then, please?
Thank you.
So we know that from the evidence that we've looked at, specifically when we look at the groups and the systematic reviews, the quality and the valuation of interventions needs to be improved. That's clear. That's a consistent comment in all the reviews. We know that means restriction shows consistent evidence of effect in reducing suicide, but these are population-based interventions, and we need to be mindful of that. But also, as Robert mentioned earlier on, is that there's no one intervention is sufficient to reduce male suicide. There's no magic bullet. As the Finnish programme demonstrated, it's a whole range and raft of strategies that are multi-layered and multifaceted to try and reduce suicide in these areas. There's evidence of some effectiveness for discrete populations with, say, prisoners, people with psychosis, etc. But these need to be extrapolated to the wider population and some of the challenges involved in that. One area that is being highlighted particularly by Professor Louis Appleby and his group is that there's this idea that men don't come forward to seek help, and that's not the issue. Men do come forward to seek help. It's where they seek help from, or it's the response they get from services and different organisations that may require attention. So maybe it's about services and statutory organisations, how we think and how they think about how men present to services and what we need to do. Maybe we need some type of red flag identification with males who come forward trying to seek help. And as I've said before, we need to listen to men more. We need to increase the opportunity for research, but particularly qualitative research. And I'm sure we'd be happy to get involved in that if we did. So,
Sure.
so that concludes our first section for the time being.
Just to add a little bit of more detail and to think a little bit about other information we have from within Wales. So if we could have the Bangor slides back up. Thank you, Kerry. Doing a brilliant job there. Thank you. Over to you guys.
Okay, so Claire mentioned the real-time suspected suicide surveillance data. This is data collected by police service, essentially, where they encounter incidents which they suspect to be suicide, and they do that against agreed criteria. The figures relate to people who are ordinarily resident in Wales. So they're not necessarily every case that occurs in Wales, but they are cases of Welsh residents. Forgive the use of the word cases. I don't mean to dehumanise the instances at all. There were 356 incidents and 78% of them were male. So we're seeing, as we would expect, a very significant preponderance of men. And the highest risk age group were 35 to 44, followed by 25 to 34. Methods of suicide, 63% hanging, 15% overdose, and 5% jumping from a high place. In terms of area, as John mentioned earlier, there's a statistically significant higher rates in Mid and West Wales, which one would presume relates to rurality, and that's a common find in many countries. Could I have the next slide, please? Oh, okay. Just to say more about deprivation and unemployment, because that seems to be lost somehow, and it's coming up later. There's a statistically significantly higher rate in the most economically deprived parts of Wales as compared to the least economically deprived. That's unsurprising. And unemployment is a massive risk factor. Unemployed, if I remember correctly, are 12 times more likely to take their own lives than retired people, who are the next highest group. 74% of individuals were known to the police. What exactly that means isn't entirely clear, as in a significant proportion of them are either a suspect or known perpetrator, but some are known to the police as being a victim or being vulnerable. The information about whether individuals have had mental health contact is at this stage of the system, and obviously I know people are aware of this, and it's going to be an evolving surveillance system, but 47% of people who've been in contact with mental health services were thought to have had a mental health problem, and 22% to have been substance misusing or alcohol problem individuals. There's quite a high rate of individuals who are known to be the perpetrators of domestic abuse. Now, the problem with the figures that I've just mentioned is that we don't know what the denominator data is. What that means is we don't know what proportion of individuals are known to be domestic abuse perpetrators, so it's impossible to compare suicides with the population generally. But one would assume that 19% as a rate for domestic abuse perpetration is a very high rate and would appear to be a risk factor. Another worrying bit about the data is that in 30% of cases, we don't know whether or not people had had contact with mental health services. But as I said, it's early days. The system will evolve, and hopefully we'll get better capture on some of this information. Next slide, please. Okay, so I've covered some of this. These figures relate to Welsh residents. The deprivation finding I mentioned, and the unemployment figure I also mentioned. And we need to address some of the uncertainties around what it means to be known to the police, and the incomplete data with respect to whether people are known to mental health services. But there's a lot of really useful information in the system, and it should help us in thinking about suicide prevention and where best and how best to intervene. Thank you.
Okay, thanks, Robert. just talk about a little bit about the groups that Luke and Scott facilitated in Cardiff and Wrexham, and just following on from the film. Really want to pay thanks to Luke and Scott. Really, they sent us the information and their analysis, and I'm just taking the credit for talking about it a little bit more than they are, really, because we didn't really need to add more particular elements of analysis to it, really. But we've got some thoughts and some findings related to that. I attended the Wrexham meeting, and it was excellently facilitated. I was surprised, like a number of the representatives talking there, about the range and number of groups that were available in Wales and North Wales. I'm pretty sure that there's a hell of a lot more groups out there that are men's groups that don't particularly have a mental health element to them, but have a mental health benefit to them, should I say. And I think that's where we need to be mindful of that. But in terms of the facilitation, Luke, they posted 3 questions in terms of, as they've highlighted there, what issues do men bring to your groups? What helps most in your group? And how could a men's network help your group, or help men in particular? Next slide, please. Now, these are some of the findings and the themes that Luke and Scott identified, and we wouldn't disagree with any of those in terms of the evidence that came out. What's interesting is that, looking at the RTSS data, finance, employment, isolation, substance misuse, people with physical and mental health problems, these relate to some of the issues that are found within that data, suspected suicide data. So there's a lot of links there in terms of what men are coming to these groups for, and talking about, and exposing themselves, and exposing their emotions, etc., and how that links up to the real-time surveillance data, and some of the cases that are present there. What the groups provide are, kinship, listening. They seem to be all the issues that, for some men or people in general, don't receive from statutory services, and that seems to be the benefit of these groups. There's an acceptance. There's a freedom of expression. There was a couple of exercises in the Wrexham meeting where one person spoke at a time, and really everyone listened, and that was quite interesting, I have to say, and quite powerful for some of the men attending there, and for even some of my colleagues and myself who attended it, really. How could they improve on this? Well, obviously there was a national network spoke of. There was support, refunding, and about sharing successes and making links, as some of the participants have identified. There was also this idea about further training for facilitators around mental health, and particularly suicide awareness, in terms of how the facilitators could be helped. Next slide, please. So some of the findings, some of the comments that we thought we'd come up. Obviously, a national database would be helpful by locality, which is continually updated and advertised widely in a range of areas and service settings. We thought Public Health Wales could be responsible for this, given that they set up these initial meetings. I think in order to keep the momentum going from these 2 groups, we thought either an annual or biannual meeting, either north and south, to again keep up the momentum, but probably to identify and attract newer groups that are probably out there in terms of their help in supporting men. We also thought that, no statutory involvement of these groups. The benefit seems to be that they've been set up and developed organically, and there are no bureaucracy, no forms to fill in. Men just rock up, men just show up. Once they find out the group's there, there's no referral system, etc., etc. So we thought a hands-off approach from statutory services in terms of the running and the identification of them. But I think I'll say a little bit more about that a little bit later on. We thought specifically for group facilitators and people who run these groups, there should be identified sources of support and funding to maintain the group activity and to continue to support a range of activities, such as there was a lot of outdoor activities that some of the groups got involved in. There's a particular group in Wrexham that's I think it's Dragon Talk. They do a lot of that's based around Wrexham FC, etc. So there's a lot of these groups that require a little bit of funding, and identifying that and supporting these groups with that would be really beneficial moving forward. And next slide, please. We also thought that when these groups are set up, it's about taking support to where vulnerable men are and where men are congregating, for example, in these groups. There's been a number of initiatives in North Wales and no doubt in the rest of Wales and in the UK where there's been like a one-stop shop in terms of, say, the homeless, where we've had people with substance misuse, financial benefits, employment and other specialists being available to various groups to provide support and direct sort of access to other services and direct information about services. We thought these men's groups were a sort of ripe area for these type of one-stop shop events where men could receive support from a range of different services, or even be pointed and supported to access these services. We also thought about training for facilitators. Now, I know I mentioned earlier on about gatekeeper training was more beneficial if people had direct access to follow-on services. I mean, we've had some thoughts about that, and maybe signposting might be a beneficial intervention that facilitators could get involved in, but not direct referral into services, because there might be some caveats to that might be difficult for them. And then the groups take on a different meaning, and we don't want to lose that. And again, as we've highlighted in the dearth of research and the dearth of qualitative research with men, we thought that these groups would be a useful area, obviously participants willing and consent to conduct some further more beneficial research into some of the areas that have been highlighted in some of the systematic and scoping reviews that we've examined. I think that's our second presentation complete.
Thank you very much. Thank you, Robert, Stadia and John. Really interesting stuff, and thanks for all the work that you've done to pull that together for us today.